I'm Harold Pollack. I'm here talking to some of the authors in the J. Hipple special issue, part one, on the Affordable Care Act at 10 years. And Professor Michener, I'm very happy to have you here today. Why don't you tell me who you are and what you do?
All right. Hi. Thanks for having me. This is fun. I am Jamila Michener. I'm an assistant professor in the Department of Government at Cornell, and I study poverty, public policy, racial inequality, all the fun stuff.
It's really, I don't know why you picked such a narrow niche area.
I wonder every day now.
So now, you wrote about the racial politics of the Affordable Care Act. And now the Affordable Care Act is really not about race policy, it's about health insurance. Why is race a valuable lens to look at the trajectory of the ACA?
Yeah, I mean, the first thing I would say is that in many ways, the Affordable Care Act is about race policy because race and healthcare are sort of intricately connected, both because there are so many disparities and so many disproportionalities in terms of health outcomes and access to healthcare, and because the Affordable Care Act itself, the act itself in many ways sets up race and ethnicity and reducing disparities around race and ethnicity as a goal of the legislation. So while it's not sort of front and center when you're sort of, watching Obama's speeches about the Affordable Care Act, if you look at the act itself, it becomes really clear that the kind of designers of the Affordable Care Act very much had racial and ethnic disparities in mind when they wrote the bill. Mm-hmm. So I think when a law is written with that kind of a goal in mind, and then it's fair to sort of assess it through those lenses.
Mm-hmm. Now, as I recall, the president of the United States when it was passed was African American. I'm a little hazy on that, but
I think that sounds right. It does.
How much did that racialize the Affordable Care Act?
Yeah, so there's cool research on this cool/depressing, depending on your perspective on it, that essentially shows just by having the Affordable Care Act be associated with President Barack Obama, healthcare has become racialized, right? So that the kind of racialization of President Obama's presidency has spilled over to racialize healthcare. And if you talk to people in the 1990s when President Clinton was attempting to make various reforms around healthcare reform, and you compare that to the way that people viewed the Obama administration's attempts to successful attempts to reform healthcare, that there are many more people whose attitudes are sort of attitudes towards the Affordable Care Act are kind of focused through the prism of race, either implicitly or explicitly. And that's essentially because it's associated with an African American president. So race is sort of baked in there, whether we want it to be or not.
Mm-hmm. So when we actually look at that issue, putting that issue aside for the moment, when we actually look at the ACA itself, what are some components of ACA that at least were intended to reduce racial disparities in health outcomes and health status?
Yeah, I think the biggest one is really the Medicaid expansion. And so it's not as though the Medicaid expansion is billed as kind of racial policy, right? But everyone who is writing that law, at least in its original form, which was it was going to apply to all the states, knows that Medicaid disproportionately serves people of color, so that African Americans and Latinos combined make up 50% of the Medicaid population, even though they're not 50% of the population of the United States. And the primary reason for that is because of the kind of racialization of poverty. So low-income people who are living in poverty are more likely to be African American and Latino. And that means that when we sort of shifted the criteria for Medicaid under the Medicaid expansion away from these kind of categorical criteria that were about, what group you were in, and towards, a metric that was just about your income, it was going to bring many more Black and Latino people into adults into the fold of Medicaid. And so that was was going to be the primary mechanism through which the Affordable Care Act really reduced racial disparities in terms of access to health insurance coverage.
Now, how successful has the ACA been in achieving that?
I mean, it's been somewhat successful in the sense that, there are more people, because of the expansion of Medicaid, there are more people who are covered by health insurance than were before. And many of those people are African Americans. And there are some disparities that have been, in terms of access to healthcare, that have been reduced as a result. However, the expansion of Medicaid as originally intended, which was to apply to all states, isn't what happened. So several states sued the federal government, and the Supreme Court decided that a determination that all states have to sort of toe the same line with respect to Medicaid expansion was coercive. And they said, well, states can choose this. And so some states chose it and some states didn't. Now, the states that have ended up not choosing to expand Medicaid are many states that have really substantial populations of either Black or Latino Americans. So states in the South, for example, are disproportionate among those that chose not to expand Medicaid. So those states, because they're out of the picture, really dampen the effect that Medicaid expansion could have had vis-a-vis reducing racial disparities in access to health insurance.
What's interesting, by the way, is if you look at a U.S. map and you look at the states that declined to embrace the Medicaid expansion, you see a bunch of states all across the country. You see the South, but you also see, Idaho, Utah, Wyoming. If you actually redraw that map and you weight it by population, you see that 90% of the people who are affected are basically in the Old South, Southeastern, and it really, which is of course where certainly where huge groups of African Americans are, and in fact, if you look at the states that have slowly taken on Medicaid, it's often these pretty small majority, almost really dominant white populations like Utah, the ones that have had the
ballot initiatives,
and it's interesting that it's a heavier thing to do in Texas or Georgia than it is to do in Utah or Idaho, and it does seem like race. It's almost inescapable that race has to play a part there.
Yeah, and it's interesting. I've talked to some of the folks in Utah, for example, some of the folks that were involved in the advocacy work around Medicaid expansion in Idaho as well. And when I have conversations with them, they acknowledge that it would have been a much heavier lift and possibly an impossible lift if it weren't for the levels of homogeneity that they have in those states, right? So the people who are responsible for Medicaid expansion in those states are fully aware that the kind of mass mobilization and support required in order to get people on board with passing Medicaid through things like ballot initiatives require that you want those other people in your state to have that. And if you think those people are really different than you, that there's some racial other, you're just less likely to support that. And there's research, to support this conclusion too, that attitudes about Medicaid expansion are both vary based on the race of the person holding the attitudes, but also based on the racial composition of the state that they live in. So that when white Americans in particular live in states that have more Black people, they're less likely to support Medicaid expansion. Now, who knows what is in people's hearts and minds? And some of this stuff is implicit, likely, but it certainly emerges in the patterns that we see in data.
By the way, of course, there's other things that matter too. There are class antagonisms and
yes, absolutely.
other things, people's attitudes, for example, about addiction and, to the extent that Medicaid is covering a set of behavioral health issues that people might be ambivalent about. Obviously, race would not be the only factor that would be at play here, but it's certainly one of the important ones.
Yeah.
I'm reminded, Alec McGillis had this amazing story about, he spent a lot of time and Sarah Cliff also spent a lot of time in Kentucky, West Virginia. Basically,
I remember that story.
Yeah, it's sort of amazing. Like, why are people voting for candidates who want to repeal the ACA when so many people in these communities are depending on the ACA? And there was a tremendous amount of resentment that was not racial, but that was like, my cousin, who's a total screw up, has better health insurance And one of the weird things was that the fact that Medicaid was doing a pretty good job of attending to people's healthcare needs became a source of great resentment for people who had private coverage that they viewed as not as good. So I can't go to the emergency room. My cousin, who's got like an oxy problem and can't hold the job, he can go down to the emergency room for free. I can't do that. And I mean, there were some very interesting, very visceral reactions that people were having that sometimes were racial and sometimes were, non-racial.
Yeah, I mean, I think for any story where race is a part of the story, it's almost never the full story, right? Because the world is complicated and people are complicated and they have multiple motivations and different lenses through which they're viewing the world. So I would never say like, this is all about race, you know? I do think that a lot of the other factors tend to be intertwined with race, and sometimes they're distinct. And so it's important for us to understand that kind of full complement of things that are kind of moving people to either support or oppose these policies, because it shapes the possibilities for the future and the trajectory we're on with regard to, healthcare and health coverage. And so I think ignoring any really major factors is something that happens to our detriment. And I would say race is a major factor. It's not the only one, but it's a big part of what is shaping the way that people think about these things. And it may or may not be something that they would express, right? if a journalist asked them, or if, an interviewer, I interviewed lots of Medicaid beneficiaries for my book. And one of the things that was funny was that the beneficiaries who were people of color, they did talk about race and how it shaped their experiences with the program. And the white beneficiaries didn't, right? So how much it's on our kind of radar explicitly varies a lot too. And it's certainly a tricky thing to sort of trace and understand. And part of the motivation of the paper was to kind of bring it to the fore and try to start to understand as much as we can about how it might be working.
By the way, since you mentioned your book, I should ask you, tell me a little bit about the book and how and what you were doing there and how it sort of fits into your own research agenda.
Yeah, so the book focuses on Medicaid, which I'm sure by now folks think that I'm obsessed with, and that's accurate. I am obsessed with it. But in particular, I try to think about people's experiences kind of on the ground with Medicaid, whether it's, at hospitals and clinics or in, agency offices or in various different capacities, and how those experiences vary across states and localities and counties, and what that variation enabled by federalism really means for people's experiences, and ultimately how it translates to their political lives, to their willingness to take political action, to the way that they understand themselves as political agents, to their ability to have a voice in our democracy. And what I find is that it really matters, and that the differences and experiences that people have across place are also shaping differences in their kind of engagement in the democratic process, so that Medicaid and federalism are like policy wonky issues that I care a lot about the details of, but on a larger scale, they're also relevant for our democracy. I think in the book, race comes up again because I'm talking to Medicaid beneficiaries who mention it, but it was hard for me to quite figure out the role and incorporate into the book fully the role that I thought that it was playing. And so it was something that remained sort of in the back of my mind and something that I wanted to be sure to think about as I went forward. And so when the opportunity to kind of think about this piece emerged, I thought, well, I know what I want to look at and dig into. I want to look at the various ways that race is implicated in the ACA and sort of think through what existing patterns over the last 10 years since the bill has been implemented show us about the relevance and implications of race.
Now, one thing you mentioned, so we talked about the Medicaid expansion, there's other components of the ACA that also have touched the issues of race. And I wonder what other components you would identify as important in that.
Yeah, the ACA is this mega legislation that's just thousands and thousands of pages. And so, it would literally, I don't want to say impossible, but it would be close to impossible for me to fully sort of, explicate every aspect of the ACA and how that might intersect with race. But some of the big,
about 7 hours here.
we can take our time. We can be here all night.
That's right.
My kids will feed themselves.
No, stay on, yeah.
Exactly. No, but there are some pieces that I think are especially important and tend to be understated. So, one is explicit language in the ACA around non-discrimination,
Mhm.
and non-discrimination with respect to health insurance programs and various other aspects of the ACA. There was a recognition that when the ACA passed, people were going to be sort of more deeply pulled into the healthcare system. And that in the process of pulling people more deeply in, we wanted to make sure that they weren't going to be discriminated against on the basis of race and other kinds of characteristics. There are also parts of the ACA that talk about, healthcare workforce diversity. And this is something that's been on the radar for people who are kind of on the healthcare system side of things for quite some time. That when we look at doctors and nurses and people who are kind of staffing hospitals and medical clinics, they don't look demographically the way the people who are receiving the services look. And that's not just about some kind of descriptive alignment or superficial alignment. It really affects the nature of the care that people get. And so changing something like that has implications for health services that people will experience. And then a big one as a researcher is that the ACA has, some measures that ensure that data will be collected thoroughly about race and ethnicity through different government surveys, and that as different people are receiving healthcare benefits, we're going to actually systematically track metrics around race and ethnicity so that we know how much of a problem it is, where and how it's an issue, and we can kind of understand the contours of inequity and be better prepared in the next round of policy making to understand how to make policy that's going to create equitable outcomes. But all of those things required implementation on the part of federal and state governments. And that's the piece that I talk about in the paper. It's the tricky piece.
So say more about that. So how has the implementation been going in those pieces?
Badly. For the most part, in many ways, it hasn't been going at all. In part because the kind of the actors that were most crucial for moving implementation along were often political appointees. And so when the administration changes and you have political appointees that have new prerogatives that aren't necessarily as concerned with data collection around race and ethnicity, and aren't necessarily as concerned with workforce diversity and non-discrimination, what happens is without that kind of leadership to ensure forward movement, you kind of get things stalled out. And many of the funds that were supposed to be, or that were initially appropriated to make these things happen, are contingent on continuing appropriations, which depends on Congress being able to agree on those sorts of things. So both the kind of change in administration, the structure of who was responsible for making these things happen, and the kind of reliance on political appointees in agencies that are highly politicized and politicized often in ways that implicate race. And then, just the kind of the funding situation and how it's affected by the current polarization in Congress. All of those different dynamics that were kind of built into the design of the ACA for some of these initiatives around race have really led to many of these things just stalling out, petering out, and not happening.
I wonder, I did have some hopes when President Trump was elected. You could imagine like a George W. Bush,
Yeah.
a conservative, but not a race conservative, to use it, if one could put it that way.
Yeah.
That you could imagine that a different Republican administration would have taken a free market approach to the ACA, but would also have made some very different decisions about the implementation. And I was disappointed that President Trump didn't find a way to get with Republican governors. There's a lot of Republican policymakers in states that have not expanded Medicaid who would like to expand Medicaid, but they need a politically dignified path to get there.
Yeah.
In part because of the racial politics of their state and because of other, in the partisan polarization. And I was kind of hoping that the Trump administration would come out with some sort of an FU President Obama Medicaid Expansion Act of 2017 that liberals didn't like, that really was mean to left-handed Inuit cello players, but that basically gave some kind of a path where Republican governors could say, we're going to expand Medicaid. This gives us a way to expand Medicaid. To some extent, work requirements may be one way that you could imagine that could play that role, although it seems to have been mostly enacted in states that have already expanded Medicaid and want to now impose those requirements. You could imagine Texas saying, okay, we'll expand Medicaid with a work requirement. It's not a liberal policy, but it's one that, for people who've just had a stroke, they would, that would be good for those people. And it somehow hasn't happened.
No, it hasn't worked out that way. And I think, if anything, in many ways, it's worked out the opposite of that, where the Trump administration has, for example, allowed states to, states have applied for work requirements and have sort of gotten this opening where they realize they can petition for work requirements even without having expanded Medicaid, right?
Yeah.
And so it's really no expansion and in fact, an attempt at a significant retraction. I take your point and I agree that it's not necessitated by sort of partisan transition of political administration, of presidential administrations, that these things sort of stall, or that none of this is possible, right? Mm-hmm. It's possible to imagine a Republican administration that would still have been committed to some subset of these things, of the kind of initiatives or policies that would have contributed to the reduction in racial disparities. So that's possible. It's certainly not the way that it has worked out in this scenario. And even with work requirements, it's questionable whether, even if, all of the Republican states that have declined to expand Medicaid to this point decided that they would expand, but they would do so with work requirements, I think that would certainly mean that many more people would have access to health insurance. And so that's a net good, right?
Yeah.
And if you have a stroke, or if you have any number of conditions, you get access to health care. And I think that that's absolutely crucial. But it's not clear that that would have led to a reduction in racial disparities, which doesn't mean that it wouldn't have any value. But it does mean that, depending on how the work requirements were implemented, depending on who was disproportionately affected by those work requirements and what kinds of sanctions came with them, and who was most likely to be at the losing end of those sanctions, it would be possible to see sort of a rising tide in terms of people having access to health insurance, but still inequitability in terms of exactly, which boats were getting more or less lifted along racial lines. And so it's one of the reasons why in the paper I talk about the ways that work requirements can actually perpetuate some of these racial disparities. If you think about some of the populations in the kind of adult Medicaid expansion group that might have a hard time with work requirements, well, people with criminal records who may have a harder time finding work, and we know this group is disproportionately African Americans, and people in general who have a hard time finding employment. And we have enough audit studies at this point to convince us that it's just more difficult to find employment in the low-wage labor market as a Black or Latino person. And so to make work the pivot point around which we give people access is itself a racialized decision. Whether people are explicitly thinking that or not, I have no idea. I always tell my students, I don't know what's in anyone's hearts and minds. And I don't particularly care. But I think we know the outcome, given the kind of structure of American political and social life, is that by tethering health insurance to work, you are making it likely that Black and Latino people are going to have less rather than more access relative to whites.
By the way, it's interesting that there's many strands in here. When you were describing the non-discrimination components of the ACA, it reminded me of an earlier time when Medicare was debated. A lot of people do not remember that Medicare actually is what desegregated Southern hospitals.
Absolutely.
And in fact, when Medicare was being debated, people understood that was what was going to happen. And some of the opposition to Medicare was definitely coming from people who were like, this is going to bring desegregation. But what was amazing was all of these Southern medical providers, and not just Southern, but wherever there was segregated facilities, many of the providers who said, we could never desegregate. Our white patients would never tolerate that. Our communities would never tolerate that. And then when Medicare was passed, and what's now the Center for Medicare and Medicaid Services said, well, that's okay, that's fine, but you can understand that we're just not going to pay for any patients over the age of 65 in your hospital. A lot of these providers suddenly said, oh, on Tuesday we'll desegregate.
And you know what? This is great. It's a great example, and it's one that I use with my students in my public policy class. And there's a great book, a kind of historical exegesis of exactly what you just talked about, called The Power to Heal. And recently there's a documentary that was produced that's a kind of offshoot that's based on the book, and the documentary is called The Power to Heal. And I showed it to my students last semester, and then participated in a screening of it in my local community just a few months ago. And I was astonished by the number of people that would come to me and say, we didn't realize that Medicare was responsible for desegregating, in particular Southern hospitals. I think it's a history that is very much lost. And it's one of the reasons why when people think about Medicaid and Medicare and healthcare, they think of it in this separate bucket from racial politics, right? But we know historically that these buckets have often, come together, and they're not the same thing, but they've been interrelated for quite a long time. And I think Medicare is a great example of this. I highly recommend the documentary, or the book. One of the things that I think really comes out there is that Southern hospitals, even after it became clear that in order to access Medicare monies, they were going to have to desegregate, still tried not to do it, and essentially just tried to lie and say that they had desegregated when they hadn't. And so in order to enforce and compliance, the federal government had to be, and Lyndon Johnson in particular was super engaged and active around this, and actually relied on a vast network of healthcare providers who cared about this issue and wanted to see desegregation happen. So dentists were huge here because they weren't tethered to the American Medical Association, so they didn't have as much at risk with their career. But nurses, hospital staff, who actually went and evaluated hospitals to make sure that they didn't just move one Black patient into the ward for half a day while the compliance officer came around, but to make sure that they really were fully desegregating. So it took not just a law, but a sort of committed presidential administration, and then consistent enforcement. And I think that one of the things that I don't talk about this piece, the Medicare piece in the paper, but one of the things that resonates with the paper is that in the paper I'm pointing out that we don't have those things with the ACA anymore. We don't have a committed executive, and we don't have a sort of body of people who are helping to ensure compliance with the ACA. And so just as we wouldn't have seen compliance with Medicare in the 1960s, in many ways we don't see it now in the present, because that sort of thing doesn't happen magically. It happens through continued political pressure.
Although what's interesting is that the ACA repeal really brought out that there was this broad constituency for Medicaid in particular.
Yeah.
And by the way, so my wife and I take care of her brother who's disabled, and we saw very much that middle-aged women connected with loved ones with a disability basically said, if you try to repeal or cut Medicaid, I'm going to come for your job. And then and you just do not. Those are the true the most terrifying people in American politics.
Absolutely. And they've saved Medicaid again and again.
And now I must say that was not a debate that I think of as being particularly around the racial politics of Medicaid. It was really around communicating to the American public in a way that was in some ways specifically intending to bracket the racial issues, to say, hey, think of this person who uses a wheelchair. What's going to happen to that person if you block grant Medicaid? And a lot of the poster children for protecting Medicaid were definitely not Black and brown men and women and children. And I'm sure that was people were conscious that it was important to present the right picture, so to speak.
Yeah, I think that's exactly right. It's interesting. In the book, I interview people from advocacy organizations who advocate on behalf of Medicaid beneficiaries. And one of the things that I ask a lot of these folks about are their strategies and the extent to which Medicaid beneficiaries themselves are a part of the advocacy strategies and the advocacy and organizing activities. And many of these folks told me explicitly that when they need to pick someone whose story to highlight, they pick someone who they think is going to be sympathetic on every front. So it's going to be a widow and a white woman and somebody, who is either, has a disabled child or what have you. So I think there are strategic ways of there's a strategic approach to thinking about, how you can draw together different constituencies via Medicaid, the kind of traditional poor who may be disproportionately Black and Latino, but through Medicaid have some shared interest with middle-class people who have disabled children or disabled family members, and how can we build on those shared interests? And I think that, when Medicaid has seen success and when it's been protected, it's when those shared interests have been built on. But I also think it informs a strategy for eroding Medicaid, which is a divide and conquer strategy. So work requirements are a divide and conquer strategy. Although they ultimately will affect, many people who are disabled, the perception is it's not going to affect grandma in the nursing home. It's not going to affect people who are severely disabled or who have other medical conditions. This is just for the other people who you also might agree with me shouldn't necessarily be getting this benefit. So I think that in the same way that those kind of shared interests hold hope for collaboration that allows people to organize interracially and across race, and that in some ways kind of brackets race or makes it sort of less visible. There's also the other end of this, which is if you racialize subsets of Medicaid beneficiaries, you can take advantage of those differences and you can splinter support for the program. And that's very much been the strategy of Republicans for quite some time.
There was a very specific effort. In fact, there's political messaging, which I think is very much was both aimed at the disability community, but also aimed at people who value the disability community, which is almost everybody.
Everyone, yeah.
That basically that the ACA Medicaid expansion has harmed the disabled, and that because states have the burden of this Medicaid expansion, that it makes it harder for them to care for people with disabilities through Medicaid, which is actually, there's no data to support that. But what's interesting is it did not work. As a political strategy, it did not work. And which is, I mean, I do think that one of the lessons of the ACA repeal is going after Medicaid overtly. You can say, let's put in a work requirement, and that's popular. People do believe that people who are getting health insurance should be working. I think that is something that is deeply, that belief, right or wrong, is one that is widely held. But the idea that I'm going to cut Medicaid as a I think that is a strategy that after 2017, I think a lot of Republicans are going to say that wasn't our best approach to the problem. And although I'm sure that you're right that there'll be efforts to try to splinter the Medicaid population, I do think it was a pretty emphatic defeat. When you have both houses of Congress and the presidency and you fail to pass a piece of legislation, people take note of that.
Yeah, no, I agree that, the support for Medicaid is widespread and it's massive and it's a good thing. It's actually kind of incredible given the widespread levels of support for Medicaid that these attempts have been consistently made and that they've come so very close to being successful. I think that itself says something, that the attempts were not successful says something about the resiliency of Medicaid, but that they came so close to being successful says something about the fragility of the coalitions required to hold together the level of support that a program like Medicaid needs in order to function. And so I think there's both, kind of positives there, and I think there are some worrisome aspects to that. And I think, as we think about the future of how to hold together the coalitions needed to hold together a program like Medicaid, it's all the more important not to ignore some of the openings that could be created, the kind of cracks, the wedges that could be pulled open by kind of capitalizing on racial differences in who benefits from the program, and who we think deserves it or doesn't deserve it or what have you. So I think that's actually, the political consensus and kind of the collectives needed to support Medicaid suggest that we should be paying attention to how it's framed, how it's discussed, and when and how race is either explicitly or implicitly invoked in the political processes surrounding it.
One thing, as you were saying, that I think is also a part of the equation is that healthcare providers are such a critical part of the politics.
Yeah.
And the people of color who are quite sick or disabled are extremely important for healthcare providers who need to be paid for the work that they do.
Yeah.
The guy who left the state prison, or the single mom who's healthy but is low income, she's really economically, providers she's not so central to the economic calculus of the university academic medical center or the state, the oncology society or whatever. And so there is a vulnerability that some of that some of the low-income folks who most need basic medical care, they're not as crucial for other constituencies to defend.
Yeah, and at the same time that they're not as crucial for other constituencies to defend just because they're not contributing as much to the financial bottom line, they're also much easier to scapegoat, right? They're much easier to sort of to depict as some sort of undeserving group of people who either, are responsible for their own fate or are not working sufficiently hard enough or what have you. And so, there are political outcomes that can make that kind of scapegoating unsuccessful. And I think we've seen it largely fail to resonate at times. And then there are ways to structure policy to really try to highlight those kinds of strategies and to try to leverage them. I think work requirements have essentially been about that. We're going to carve off this group of Medicaid beneficiaries and say that they're less deserving and say that we want to do less for them and we want to have a higher bar for them to meet in order to get the same benefits. And I think at least the present administration, Seema Verma at the CMS, has been quite explicit in trying to trying to pit those folks against, for example, the disabled community by saying, we can help people who are truly in need more effectively if we get rid of or give less to these people over here who are only sort of in need. And that hasn't resonated as strongly yet, but it could, right? Especially as people get accustomed to and get more used to our policies like Medicaid work requirements. Before, work requirements just weren't on the horizon for Medicaid. And as they kind of sink into people's consciousness and become part and parcel of what is accepted, I think it does open the door for more and more of that kind of divide and conquer, carve off the most deserving groups to weaken the political strength of Medicaid. I think that's more and more of a risk and possibility as we go forward, at least if it's not something that folks are cognizant of and remain aware of. So
we're reaching the witching hour.
Yeah.
What have I not asked you that I should have asked you? Or what are some closing thoughts that you've had occasioned by this conversation?
I guess, the closing thoughts are really, two things that I struggle with how and whether to bring into this conversation and are the kinds of conversations that are similar to this one, are how do we think about the policies being proposed now, for example, around Medicare for all. So some people, when I have this conversation, say, see, that's right, Medicaid expansion doesn't work. When you carve out these different groups, some people are going to be, there are going to be all of these political opportunities to, try to, divide constituencies, et cetera, et cetera. This is why everybody just needs to have Medicare for all. And I always keep that conversation separate from this one because I see them as sort of related but distinct. but I always have a sort of back of my mind discomfort with keeping the conversations too separate because they are related. So that's something that I would just flag. I don't know that I have anything particularly insightful to say about it, but it's something I would flag. And the other thing, of course, is the pandemic that we're in the middle of, and the implications that that has for how we think about, both racial and ethnic disparities, and just widespread access to healthcare. I jokingly on my Twitter page earlier this week sort of jokingly and also seriously made mention of the kind of myth that had been going around that I heard from family members of mine that don't worry, like Black people are immune. And it made me think about the ways that there's a deep distrust of the healthcare system and of the government, such that, there can be entirely different ways of understanding health, public health, and wellness in these communities. And part of the way that that's fueled is by the kinds of inequities that the paper addresses. So it might feel like the present pandemic has nothing to do with the kinds of things that we've been talking about this whole conversation. But I guess if there's anything I would say is that the current political moment we're in vis-a-vis how to deal with access to healthcare, vis-a-vis how to deal with a pandemic that is going to affect people inequitably. All of these things are both distinct, but also interrelated, and connected to the larger project of really holding our own feet to the fire by pushing ourselves to think about race and equity when we think about healthcare, health policy, and ultimately, I would say, health justice.